Let's see.
Hi, Anisha.
Hi again.
Hello. So we'll just give it a couple of minutes and then whenever you want, you can get started.
Okay.
Maybe just let a few more people roll in. Anisha, I don't know if you've heard from anyone else if they're coming on. I know
Yeah,
they
I
know
think
you're
they
presenting.
would. I'll just text the group.
Well, I can just walk over there.
Well, I mean, we just had a PEC meeting. They know that she's presenting.
Yeah, I
So,
didn't want to text also. It's okay.
do you want me to? I can text
Um,
them if you want.
On Thursday? Oh, I don't.
Hey, Anisha, whenever you want to get started, if you want to
All
wait more,
right.
if you want to get started, I just want to make sure you have enough time.
Yep. So, well, good afternoon, everybody. Obviously, thank you for joining me today for this Grand Rounds to kickstart the fellow Grand Rounds, rather. As we all know, I think by now, my passion in sleep medicine and the reason why I even went into it was to just get better with non-invasive ventilation to integrate my background in pulmonary and critical care. So I used to be reading some of the papers by Dr. Salim and Dr. Ramar, and one of the titles was when CPAP was not enough to get a better grasp of this. So obviously the title has been incorporated from some of the papers that I had read before, and I also continue to read even now. I have nothing to disclose. Sorry. I do have a lot of ground to cover, but I mean, of course, I'll start off with a very interesting case. I do want to go behind the pathophysiology of hypercapnic respiratory failure. We encounter it quite a bit in our clinic during titrations, and I think it's important as sleep medicine fellows to work this up and to identify what's causing it. Components of NIV delivery, focus on VAPs, but maybe I can go over that really quickly because we had a really nice presentation earlier today by Roma and Dr. Gavidia. But also focus heavily on asynchronies and not coming from the asynchrony from the ICU standpoint, but from the titration standpoint. And when we see these patients in the follow-up clinic and when they are encountering PAP issues, what do we do about it? So with that, this patient is our patient. He was seen in our clinic, 68-year-old. He's a former smoker, diabetes, hypertension, CKD, chronic pain, and he's been on chronic Suboxone for more than 10 years, sleep apnea. He's been fairly compliant with his CPAP. He was diagnosed outside of University of Michigan, so don't know what his baseline sleep study really was, but he's been using his auto CPAP when we saw him. His BMI is only 25. He was established back in 2022 actually with us, and he would have nights where he couldn't use his PAP device. He would use it under 3 hours. And given the fact that he was on Suboxone, of course, we wanted to work him up more. We wanted to bring him in for a titration, but he was pretty adamant about not wanting to come in. So during that visit, it was more about improve your compliance. However, he got hospitalized after that for acute on chronic hypercapnic respiratory failure. He also had an RSV infection, got discharged on oxygen, and when he was followed up in the pulmonary clinic, they raised some red flags and said, okay, he needs an urgent titration. It seemed more like he had oxygen hypoxemia more at night because during the daytime, this is one of our classic follow-up questions is how does your saturation improve when you take in deep breaths? And he reported it was good. So that makes us think more in terms of that ventilation is the VQ abnormalities are not the major issues. It's kind of more of a hypoventilation problem. So anyway, these are his other meds of relevance. Besides the Suboxone, he's on gabapentin of 100 milligrams, amlodipine losartan. His home test, and we did a home test prior to this hospitalization, and I'll come to that when he had seen us because he was so adamant about not wanting to come in. We were like, okay, let's see what it looks like on PAP. And he had a fairly low REI of 9.6, but however, his hypoxemia was quite out of proportion to his severity of sleep apnea. So he had spent 52% of his night with SATs less than 88% on his home test. Just additional workup, CT chest didn't really show any emphysema. It had a tiny nodule. Chest x-ray after his admission was completely normal. He had no evidence of hyperinflation, even though he had a significant Pacquiao smoking history. I think it was 20 or so. He didn't have any evidence of hyperinflation. Pulmonary function test was completely normal pulmonary mechanics, normal ratio, normal diffusion. Echo was also normal with diastolic dysfunction, and this was with a shunt, so there was no evidence of shunt. His labs were definitely very prominent. He had an elevated serum bicarb of 38, and it was always chronically elevated. An ABG was done at the time of his pulmonary function test, and also the pulmonary function test was done between his visit and between the follow-up and between his hospital. So that showed an elevated PaCO2 of 63. And literally you put this on MedCalc and we can calculate the AA gradient and it was normal. So This definitely was concerning for hypoventilation of some central origin, maybe even the opioid use, but we'll come to that. So just highlighting his home test, and this was his download, showed some residual AHI elevation. So finally he came in for a titration with TCO2, and this is him in the lab. So just highlighted the most relevant things. He's supine. I mean, well, he shouldn't even say he's supine. He is actually sitting upright, or this is how he sleeps at night. So this actually might be helping a little bit. It might have even helped lower the TCO2 a little more than what it could have actually been. It could have been higher, the fact that he's even sleeping upright. So clearly he's hypercapnic. His SATs are also low. This hypercapnia is clearly driving the hypoxemia at this point as well. Just to remind everybody, the reason why this happens is because of Bohr's effect, wherein the hemoglobin has 4 binding sites, and it's usually bound with oxygen, but when carbon dioxide starts competing with it, forming this carbamino hemoglobin, the oxygen doesn't have space for it. So the saturations drop because of this, and that's why we see low SATs in patients with hypercapnia. He was transitioned to ST because of hypoxia that persisted on BiPAP spontaneous. Despite pressure supports of almost 12, 10, he continued to have hypoventilation and hypoxemia as well. Just wanted to bring up this section here where we were seeing that of course, his hypopneas were also not fully addressed, but he was not very comfortable on these settings. He was having some issues. It's just I feel like we're giving the patient a hard time with these settings. He was transitioned to ASV primarily because he was so asynchronous or uncomfortable on the BiPAP ST settings that he started having central events, and that was kind of like understood as, oh, he has central apnea, so ASV was initiated on him. Clearly, that was not the best move, as we know that ASV is contraindicated in hypoventilation. Just to remind everybody as to why this happens, we all know, yeah, we shouldn't use it. But if we understand the mechanism of what ASV basically is, it's basically not something that targets tidal volumes at all. It's all about minute ventilation. So when patients are having a low minute ventilation, the ASV kicks in to increase the respiratory rate, increase the support, increase the pressure support of the minute ventilation rather, to deliver that adequate pressure support on those times of low minute ventilation. So the machine also senses that if the prior pressure support is higher and the ventilation starts restoring, or their respiratory rate starts kicking in again, the pressure support starts decreasing. So that drives up the hypoventilation. And I will come to that. So that is why ASV should not be used in hypovent patients. So they call us in the middle of the night, and the protocol was not in place already expecting this patient for hypoventilation. So because the protocol was in place for central sleep apnea for the suspicion of the fact that this patient was on Suboxone. However, in the middle of the night, we started this patient on IVAPs, and IVAPs was started because the patient was on ResMed. And that's also what we need to learn more now, because we don't have Respironics, in the sense Respironics is not making any more vents. So at least learning ResMed would really help us. And with that being said, with the settings that were recommended, he has significant improvement of his hypoventilation. I think he starts becoming more synchronous with the vent as well. His SATs improved. TCO2 values are down to 40. He's getting his tidal volumes of 600, at times 800. That's what he needs.
What was his wake CO2?
It was very elevated. It was in the 80s. His PaCO2 even on the ABG was like 63. So he has awake and nocturnal hypoxia. For someone to develop this degree of nocturnal hypoxemia, I would suspect him to have awake as well.
So what do you think about
hypercapnia? Yep.
What do you think about dropping his CO2s down to the 40s then? Or is that just an image that you have here?
I mean, it's only good for him. It's probably overcorrecting it a little bit. As long as he's able to handle these vent settings, I think we would be okay with it. I would still be even okay with bringing him down to 50 to 60, I think. I would have been happy with a 50, really, in him. Yeah, this is quite dramatic. Anyhow, so with Any questions? Sorry, Dr. Hirschner. If there's anything else, I'm happy to, even from gathering the history or anything else, if there's any questions, I'm happy to answer them. Otherwise, I can move forward. Okay, so I just wanted to highlight a few things. When we saw him in the clinic about a year ago, more than that actually. So, one thing is that we ordered the home test. We saw that he was doing fairly okay, and he was on auto CPAP, but the hypoxia definitely should have, raised some flags there. And that is when, and if he was adamant about not coming into the lab, fine, but could we have addressed this differently? Could we have considered using the RAD guidelines to perhaps get him a device without a backup rate, which is what he could have easily qualified for with the amount of workup that he actually had? So this is an example of the E470, which is the bilevel without a backup rate. And these are all the examples of bilevels with a backup rate, which includes the ST and ASV. So without him having to come in my next slide, we had the ABG, which showed elevated PaCO2 levels of 63. He had a normal spirometry, and he had a home test. So this could have qualified him for a 470 without having to come into the lab. And we could have set arbitrary pressures. We could have considered an EPAP based on what the AutoPAP was delivering, and set a good range for his IPAP of even at an if we're starting to be conservative 6, but I would have gone straight for 10 to see how he had performed with it. We could have even followed him up with a home test on the bilevel to see if the hypoxia persisted, to qualify him then for a device with a backup rate. But all this can be done without him having to come in for a titration. So this paper that I took from the CHEST 2021 by Salim,
Can I ask you a question to clarify on the previous slide?
Mm-hmm.
Yeah. It's see where it says less than or equal to 88% for greater than or equal to 5 minutes.
Mm-hmm.
Is that interpreted as a continuous 5 minutes, or any 5 minutes that you piece together in total over the night of the study?
My understanding is it's a total of the study. Mm-hmm.
To this moment, I'm not entirely sure that I'm not entirely sure of the answer, because when I ask that to different people, I get different answers.
Right.
I thought it was
think if we want
continuous.
to qualify him, we could still make it work for him.
Thank you.
So coming back to this paper that just talks a little bit, or focuses rather on hypoventilation and excluding the VQ issues, COPD, or even neuromuscular disease, but focuses on obesity, because that's where obesity hypoventilation is primarily also in many places managed by sleep medicine. Of course, when it gets to opioid use and advanced lung disease and other things other than COPD, yes, it goes to pulmonary and other things. But if they're hospitalized, and I don't want to spend too much time on the hospitalized patients, because we do deal with consults on the inpatient side, we should be thinking of how to get them approved for an ST or a VAPS at that time. Follow them up with a sleep study, ensure that their upper airway is more stable, see if they need CPAP at that time. But BiPAP, ST, or VAPS is still shown to be superior in these hospitalized settings for these patients to be discharged on. So if that doesn't work, and then we need to get them the home vent, but that's a different beast. Sorry about the pathophysiology, but I think this is extremely important for us. Why do we care about hypercapnia? It has several consequences in regards to the cardiac system. It causes a decrease in cardiac contractility. It increases systemic vascular resistance, causes pulmonary vasoconstriction. For all the neuro folks, it causes cerebral vasodilation, increases ICP, it reduces immunity. So it matters, and it matters more as to understand why this is happening. And because what we have to understand is we treat the disease and we don't treat numbers, we don't treat CO2 levels. Oh, and that becomes like super important, even as sleep medicine physicians, to work this up. So I took this out of a pulmonary textbook, really, but the big difference is how do we differentiate these patients with hypercapnia into the group with a normal AA gradient and those with elevated AA gradient. And ordering an ABG and a pulmonary function test is fairly straightforward, and putting these numbers in on MedCalc or any other site on the internet will give you these numbers straight away. So it doesn't require any math whatsoever. So just to do a basic workup is important. Do an ABG, get a PFT, consider an echo with a bubble study. These three things before they even get referred to pulmonary will do them a huge good. And also it takes time for them to be seen. And, you know, in the interim of 3 months, you can prevent a hospitalization. You can control some degree of their CO2. So all of this becomes very important. So a normal AA gradient is what I wanted to focus on, especially in our patient, because this is driven by opioids. Obesity falls in this category. Brainstem strokes falls in this category. Obviously, the high AA gradient is all the issues that's wrong with the lungs. It could be from the alveoli to the interstitium to the vasculature, everything. But normal AA gradient is what we focus on also in our clinic. So please consider working them up going forward. Anyway, just a little bit about sleep disordered breathing and opioids. Myself, I always was very quick to consider central sleep apnea anytime I saw somebody with opioids. But there's so much more, and there's such a varied phenotypic response that varies across individuals that we need to consider more than just central sleep apnea. It reduces the respiratory drive by binding to this pre-Butzinger complexes. It affects chemoreception both central and peripherally. So this is where the loop gain phenomenon takes into account. It can directly suppress the central respiratory motor neurons that innervate the respiratory muscles. This shows different breathing patterns that opioids can do to our patients, from bitards to ataxic, biots rather, and obviously Cheyne-Stokes that we're very well familiar with. Some papers to just highlight how opioids are causing this by basically dampening the hypoxic ventilatory response. Basically, so here's the thing, it can do two. So it's a little complicated even when I was reading it up as to what really, how opioids impact the ventilatory response. So I had to go back to what normal individuals do. So overall, when we sleep, our minute ventilation goes down by about 1.2 or to about 1.6 liters or so per minute at night. There is a subtle decrease in both the hypoxic drive and hypercapnic drive for us at night. So what it does is there is a drop in SATs by about 2%, and there is a mild increase in PaCO2 even in normal individuals by anywhere between 2 to 6 millimeters of mercury. Now, in opioids, some of the earlier studies started showing how it actually caused a drop in the hypercapnic ventilatory response. And this compensatory increase in the hypoxic drive is what triggered this whole central sleep apnea. But more later studies came to show how it actually dampens both. So anyway, it's a complicated phenomenon. And I think we just need to pay attention to every aspect of what opioids can do. And it's basically that. So with that, I'm moving into my next section, which is non-invasive ventilation. And with that, I think we're very familiar with CPAP. We're quite familiar with BiPAP spontaneous modes as well, because both of this is patient triggered. Both of this is all the effort that's driven by patients. We don't have to do much with except set a range and leave them be. But what I want to spend time on is ST, and especially spontaneous timed mode, because if we get a grasp of ST, then we can get a grasp of VAPS, ASV, and other things as well. So in ST, and I'll come to each of these settings a little bit more in detail as well, but the spontaneous part of the BiPAP ST is fairly straightforward. It's patient triggered. There is the cycle changes based on the flow or the inspiratory flow. So when they're starting to exhale, it cycles out. But the timed mode is where when the device is all about what we set to the device and what we are giving the patient. So the timed mode is basically there to kick in when the patient fails to trigger a breath. everything is dependent on the TI time. And for us, for ResMed, we really need to pay attention to the TI times. To pay of note, we know that as a patient is able to take in a spontaneous breath versus a timed breath, the tidal volumes are going to be uneven between the two. And that brings me to PC mode, which is very similar to ST, except that the TI is very constant. And so the tidal volumes that are delivered in each of these breaths are very similar. And the machine is basically taking over and doing everything for these patients. It's very helpful in patients with neuromuscular diseases who are unable to trigger a breath. So PC mode, think about neuromuscular diseases. ST mode, think about patients with COPD, because you also want to give them some time in COPD to exhale. So the spontaneous breath gives them more time in exhalation. And that's their normal. So pattern of breathing. So let's move on. And VAPs, well, I know we covered a lot with the fellows earlier this morning, but just this is all purely directed with, which is volume-based, tidal volume-based rather, and Respironics is where we have to actually set a mode, the ST or a PC or a spontaneous, but IVAPS or ResMed does its own thing. So to highlight the differences between the two, of course, I said it's a manufacturing thing. So AVAPS is Respironics, IVAPS is ResMed. But the modes that you set on them is very different. Yes, right now in our lab, we might be focusing more on the IVAPS titrations and going forward because that's what we are going to be giving the patients. However, we're going to be encountering situations where patients come in on an AVAP, so that machine has been recalled, and now we need to give them an IVAPS. That is where we need to pay attention because the numbers may all look the same, but I highlighted in red here that in AVAPS, what we set is actually IPAP min and IPAP max, and that needs to be converted to pressure support and IVAPS. So we need to do the math there to make sure we actually set a pressure support min and pressure support max. A lot of things will stay the same in terms of the EPAP. The respiratory rate helps us with the backup rate. The TI, though, however, is set in the ResMed, and it complicates the whole lot deal by we have to set a TI min and a max. But keep in mind that these home devices don't give us pressures or greater than 35. So we can do anything, but we cannot recommend pressures greater than 35. Likewise, even a BiPAP cannot set pressures more than 35 at home. So unless we are like, we need higher pressures and we need to go into home vent and other things, but we cannot even be recommending pressures than a max pressure of 35 on a VAPS and 25 on BiPAP. This is obviously a different beast, which can set pressures up to 50, and I don't want to spend too much time on this. And this is a crowded slide, but this is the ARDSNet, and this is available to everybody on the internet to find out what the patient's tidal volume based on their height and gender, and how do we pick this. Go to ARDSNet and we can definitely see, and a good number will be anywhere from 7 to 8 to start off with. The whole lung protective ventilation and low tidal volumes has extensively been studied in ARDS, but normal lungs can handle tidal volumes of 8 and even up to 10. So it's a good place to start off with 10, with 8. So this is where I'm going to be focusing a little bit more time so that when I get to my slide on asynchronies, hopefully with the concept of what cycle is, what trigger is, when, which of these are actually getting activated in a spontaneous versus a machine-delivered breath, makes it a little bit clearer to understand for asynchronies. And I wanted to reiterate that the reason why I'm bringing this up is because we encounter so many titrations where there are challenges to get a good setting because they are super off, and the patient and the ventilator are just not in sync with one another, and that's why it becomes important. All right, so with that, let's start off with an easy part of it, which is the CPAP. We all know what CPAP does. We love CPAP. CPAP is super important. It actually it helps to open up the upper airway. Without that, we know that no amount of pressure support is going to work to eliminate that CO2. And we saw that example this morning wherein the patient only had a CPAP of 10, but pressure supports of like 15 or so, or 20 even. And I think the CO2 was still in the 70s, primarily because the upper airway was so compromised. And unless you open it up, how do we allow for gas exchange or the elimination to take place? So very important to address sleep apnea. Obviously, we know that it improves oxygenation. From the cardiac perspective, it also helps to improve systolic functions. It reduces the LV afterload. So CPAP's great. Now, the trigger becomes important because so the trigger sensitivity, or we always say, okay, let's set medium trigger, let's set high trigger. What do we even mean by that? The trigger sensitivity is basically something that we need to understand, that it is supporting the patient's effort. So the trigger can only work as long as the patient is able to generate some effort in taking a breath. Patients with neuromuscular diseases cannot generate enough, pressure. So they barely are able to trigger a breath. And that's when the machine has to do all of it for it. And also in these cases, you want a higher sensitivity. So even if a subtle breath that these neuromuscular disease patients can actually take, the machine is kicking in. This does not work in machine-delivered breaths. So you can set whatever trigger sensitivity you want for all these spontaneous breaths, low, high, medium, very high, great. But when it comes down to what the machine generates by itself, it entirely depends on the backup rate. And it's so important to identify and set a good backup rate for these patients based on what their neural rate is, meaning what their resting respiratory rate when they're awake in the lab, when they're in their semi-recumbent position without a PAP, is to calculate what that does. And what we can consider doing is setting 2 below that so that the machine doesn't fail to kick in when it's supposed to kick in. So trigger is important. Now, cycle, and in everything, I want you guys to try to maybe simplify it a little bit further as to what would happen in a spontaneous breath and what would happen in a machine delivered or a timed breath. This way we'll be able to further help these asynchronies in these patients, or better sync this language between the vent and the patient as well. So in cycle, the same thing comes into play as well, wherein is it a flow cycle, which is in all spontaneous breaths, wherein the machine senses a decrement in peak expiratory flow and cycles out from the IPAP to the EPAP. But however, in the machine delivered breath, this inspiratory cycle depends on the time or the TI settings. Back in the past, Respironics was super easy and it never really got complicated because you set 1 TI and let them be. But however, in ResMed, we have this extra layer of complication wherein we set a TI min and we have to set a TI max. And between the two, so TI min is the minimum amount of breath that the patient, that the time that is spent in inhalation, and TI max is the maximum amount of time that the patient gets to spend in inhalation. Obviously, you want to consider a narrower range between the TI min and max to optimize the sensitivity there and optimize the cycle so that they actually switch to expiration when the patient actually wants to exhale and they're not forced to inhale at that time. So just to put that into perspective, if we can focus on the second slide, and I just wanted people to understand what respiratory rate and how to calculate TI and TE, without that, but maybe just focusing on what our lab does is we set an arbitrary range of TI min on a titration study of 0.2 and a TI max of 2. And it doesn't get changed throughout the night of the study. So there are these patients who a majority of our patients can be normal, and they don't need that much time in inspiration. So what we have to narrow down is to consider that in normal individuals, or maybe not even in the titration, but when we are recommending settings, when we see them in the clinic, we need to bring it down to 0.8 to 1.2 in normal individuals. COPD patients need more time in exhalation, so you want to do somewhere between 1.7 to 1 because that gives them almost 5 seconds to exhale. Neuromuscular disease patients need more time to inhale, so it's more of a 1.3 on an average. So just paying attention to this will help us going forward. Now this brings me to the synchrony part of it. And I thought this slide will help all of us when we see them in the clinic, because these three questions becomes extremely important to ask. Besides the fact that, are you sleepy in a day, or are you using your CPAP? You're only using it for 3 hours. All that's great. But these questions, when they are on ST mode or VAPS or advanced modes of ventilation, is important. First question is, do you feel like you're getting a blast of air? And that is basically telling me the rise time. And patients who are not getting enough and they're like super air hungry, you want to shorten the rise time. COPD patients are always air hungry, so shorten the rise time. Now, trigger. The patient will tell you, you have to ask the question, does the ventilator provide a breath whenever you want one? And that is kind of optimizing the trigger sensitivity. Now, patients will say yes, it's giving me a breath every time. But COPD patients who have a lot of auto peeping, if you're not addressing some of their EPAP, then, even if they have to generate a lot of effort in order to get that breath, because the amount of auto peep that they have is basically the air that's retained in their lungs. So does the ventilator provide you a breath whenever you want one? Now, the third question, obviously in our sleep lab and when they're sleeping, we don't know, we can't assess this, but they will tell you the next day in the morning or when you follow up in clinic with them. Like the important question is, do you feel like your breath is getting cut off earlier or late? And this is all about cycle. But keep in mind though, that none of this can be fixed and none of this can be addressed if patient has mask leaks, uncontrolled secretions, and obviously not treated sleep apnea. Mask leaks are the biggest hindrance to this. It actually worsens the trigger sensitivity. It compromises EPAP or CPAP, and it worsens treatment of sleep apnea. It also doesn't even detect the peak flow. So if we have to address mask leaks above and beyond addressing any of these issues. I'll move on from this slide. So with that, to simplify this as much as I could simplify this, the major synchronies that we need to focus on is the rate and then the cycle. So rate could either be that the machine is delivering breaths too fast, or the patient's taking too many breaths and they're not, the language between the ventilator and the patient is totally off because of the rate at which they're set in. Many a times this could mostly be a patient issue, but cycle, as I feel, is an issue with us, and we need to address this strongly. And that is a second type of asynchronies that we have to deal with. So every time we see a titration study and we see that this is totally off, the patient's not comfortable, think about these two major asynchrony possibilities: rate and cycle. So coming down to rate. If there is an issue wherein the patient is taking breaths faster than the machine's actually delivering, so that is where the respiratory rate of the neural respiratory rate, or the time spent in inspiration, basically is higher than the vent delivered. This is a double triggering issue. We want to see if they can spend more time in inspiration. This way, the patient's not forced to take in two inspiration breaths. So give them more time in inspiration. So increase the TI time there. Give them pressure support, reduce their sensitivity a little bit. This could help with the double triggering issue. Now, if the trigger criteria is not met, or if the patient is trying to take a breath and what happens is that the machine is not delivering the breath at that time, that is an issue with either upper airway instability, so increase the EPAP. This is very commonly seen in patients with COPD as well, with basically a lot of auto CPAP, where you want to increase the PEEP so that the trigger criteria can be met. Obviously, you want to decrease the TI time there, or the TI max time, so that you optimize that a little bit better. You don't spend too much time in inspiration, and you increase the sensitivity. So, but I wanted to really focus on the TI time here. And, yes, we can play around with the sensitivity, and then that becomes very intuitive to us in the clinic. But the TI time is not always intuitive. So that's where we need to really get a better hold of. This way we can better optimize them. Now, for the cycle part of the asynchronies. Now, and I'm going to bring up some examples this way, hopefully with some of our titration studies, hopefully this becomes a little bit more ingrained, but this is an ongoing discussion. So with cycle, a large part of this actually comes down to the time they spend in inhalation. So, all right, so for the first one, or basically the flow starvation, what we need to do, so this is basically flow starvation is, how do I put it to you, is air hungry. Is air hunger, I'm not getting enough air, just rise time. Decrease the rise time, make it shorter, they're getting enough air. Think about COPD, I need more air. Now, the next part of it, which is either premature cycling or delayed cycling. And when I say premature cycling, what I'm trying to get at is that the machine is cycling out too soon. The machine is giving them very little time in inspiration when the patients want more time in inspiration. So the patient is still trying to take a breath and the machine has already cycled them out. Neuromuscular patients, they want longer time in inspiration. In these settings, you want to give them more TI time. You want to give them more time in inspiration so that this cycling doesn't become an issue. This premature cycling doesn't become an issue, rather. Now, delayed cycling is what we also very commonly encounter in our titrations, wherein patients are spending, the machine is giving them, the machine delivered breath, rather, is giving them too much time in inspiration, when the patient has already decided he wants to expire and he's already ready to start taking the second breath. So there is this offshoot that goes on. So it's almost like there's too much time, or it's like so delayed that we need to reduce the TI time and kind of best optimize it to what they need. And that's the language that we need to work with. So, sorry, I know I covered a lot. And I think, and I'm hoping for the next few slides, we have some interaction. I really do apologize that this was technical, but I feel this is very important. And this is not just coming from the pulmonary side in me, but from the sleep titrations and other things that we encounter so frequently with. So I'm going to leave this open to anyone who wants to take a gig. So I have 3 examples. And with that, I'll bring in my first one, which was also from the case report that we had. If anyone can tell me what is going on here, and I'll highlight the next box as well so that it's put out there. And I would tell me if anyone can give me what is going on with this language between the ventilator, which is an ST mode, and what's going on with the patient, I would appreciate it. So if we can break it down to trigger and cycle, throw out words there, and that'll still be okay. I see some in chat, but yeah, Roma, just speak up. But yes, no, absolutely not. Yes, great. I like the word asynchrony there. So we're getting there. We're getting to asynchrony. I think we need to say that word out loud so that we get a sense of it.
Okay.
Okay. So
That's good.
just to put it out there, if we can look at this in a very systematic order as to see, first of all, what is the machine doing? Is it a spontaneous delivery or an ST delivery? So here we can see these longer, where I've highlighted let me see. Can people see my mouse actually?
Yes.
Yes,
Okay,
we can see it.
perfect. So this means this is ST. Oh, nope, I didn't mean to do that. This is like clearly an ST delivered breath, because you can see that the EPAP's getting converted to IPAP. They're spending a good amount of time based on what the TI had been set, min or max, and the cycle's going out. All these are ST. This is ST. Great. These are spontaneous, these quick boops. This patient only wants that much time in inspiration. Now, the next thing you want to do is, yes, look at the flow, but you also want to look at the effort or the thoracic belt. What is the patient trying to breathe at? So patient is breathing faster, and at times the ST mode is kicking in, at times the spontaneous mode is kicking in, the machine's confused, all that's fine. But if one thing we can look at here, there may be a little bit issue with the cycle because the patient is trying to expire or exhale, and the machine's still kicking in, is still giving him the inspiration. So do we want to optimize their TI time here? Question mark, actually. That was for the group.
Yes.
And what would we think of doing with the TI min and the TI max?
Should we lower the TI max?
Yes, great point, Josh. And TI min? Our lab sets the TI min at 0.3. What would we want for a normal individual who has an intact respiratory drive?
I think the upper limit of the normal you said for the normal TI min is 1.2.
Yes, great, Roma, great. So 0.8 to 1.2, you want to optimize that so that you can just best get them with their TI settings so that this cycle doesn't become an issue. When I go back to my previous slide on what the delayed cycling issue is basically what's going on. Or the same question, is the machine giving you a breath longer than you want it for? And talking to the patient will really help, but unfortunately they're asleep in the titration. But in the follow-up, in the clinic, when we talk to them, we can optimize them. So that's one thing. And obviously this way, when things being so all over the place, their hypopneas are not addressed, you want to, work on all of that, but just a little bit there. This, I think we encounter far more frequently. These central apneas and these patients, despite being on BiPAP ST, but why doesn't it work? So any discussion, just throw it out there. You can text me, you can use the word asynchrony again, I won't mind, but think about what this could be, what might be going on here.
I'm uncomfortable with silence. So
Oh gosh, Steve, what are you doing on this?
I'm uncomfortable with silence.
Doing? Oh my gosh. Oh.
Okay, I think with the previous,
No.
I'll try. I think with the other slide that you showed, the one that had a prolonged central, yeah, that one.
Yep.
I think from what I can see, the machine is triggering some breath, but there's not really flow going in, and then there's basically the patient's having central persistent central apnea, and despite the machine triggering breaths.
Almost there, Oma, but great. You're getting there. You're getting there. So what happens in central apneas is that the patient is basically completely apneic and is not triggering a breath at all. So the trigger criteria is not met. So when trigger criteria is not met, think about it this way. All they're doing is exhaling, and all they're getting is CPAP or EPAP. They're not getting that pressure support. The machine is not sensing this pressure, this at all, because the patient's not even triggering the breath. So trigger criteria is not met. But this is where the backup rate becomes important. If we set backup rate of 10 in the lab, and when patients have a neural rate of 15, 16, 18 at rest, if backup rate is set only at 10, then they are probably thought that, okay, 10 breaths has been given, but say you set the backup rate too below what they actually get, the machine can actually consider even delivering the breath, can actually start that pressure support so the machine can take over. So at this point, I feel like it becomes important to really focus on the backup rate in these ST modes so that we can best consider these patients even in central sleep apneas, wherein perhaps, if we better increase their backup rate, then the machine would have triggered these subtle breaths that the patient may have wanted to take. And obviously you want to improve the trigger sensitivity as well. Yes, let's not forget those settings as well, the trigger sensitivity and the cycle sensitivity. You want to optimize all of that, but without increasing the backup rate, we may not be able to achieve that. This is for Steve, and this was the VTAC that he texted me about, and I couldn't stop laughing, but I was like, just to put it out there, again, this is a cycle issue, and also just going back, this guy had a crazy neural respiratory rate. He was like 23, 24, all these patients on opioids. It's also a little bit of a cycle issue. We can see the delayed cycling going on here, and a little bit of a Hawkeye view on how I feel like this was actually, yes, he's having these very rapid spontaneous breaths in between his ST breaths. He has central sleep apnea at baseline. The machine was working. I'm actually glad the machine picked this up, and obviously this is I think a 5-minute snippet of it, or 3 minutes. I don't really remember, but if we had given him more time if we'd given him more time, he wouldn't have felt so air hungry at these spontaneous breaths for him to pant. I feel like that's what was happening, because he was going through such prolonged apneic periods where the machine had to kick in all the time, that he was just going into these spontaneous breaths, breathing really fast, which, by the way, is actually meeting his resting rate as well. So that was a lot. And that actually brings me to my summary slide. But if anybody wants me to go back, I'm happy to do so. But I think we've all had enough. So to summarize, let's recap again that not just Suboxone, and I thought Suboxone was the most benign of all of them. Methadone was what was studied. Opioids, oxycodone, obviously those are, or narco, those are more potent, but even something as small as Suboxone, we shouldn't ignore. Yes, it causes central sleep apneas. We're great at recognizing that, but not missing hypercapnia as one of the more uncommon occurrence, but still life-saving in many ways if we can identify. Getting a grasp of what hypoventilation is, why it's occurring, doing basic workup, dividing it into the whole I can't breathe category, which is the opioids, the neuromuscular patients, the brain some strokes, and the won't breathe. The won't breathe is really easy. We can throw out a bunch of pulmonary terms there. And ASV, which should not be used in hypoventilation. I talked about why. And non-invasive ventilation asynchronies, trigger, cycle, and break it down to spontaneous and ST. And remember, this is a language between the non-invasive ventilation and the patient, and that has to be in sync. So I'm done with that.
It was great. Thank you, Anusha.
You're welcome.
Awesome. I have a question for you. I don't see anybody else's hands up or anything else in the chat right now. So what would, if when you're director of the lab one day, what would you do differently you mentioned that a lot of this comes from your experience reading titration. So do you have any recommendations of how titrations should be managed differently in real time?
Oh boy, I don't know, but I would like to think that since we're going down this ResMed road of wherein this TI is going to be on our radar, optimizing it perhaps to the big categories, but I think setting a more arbitrary TI time min and max might be more reasonable. I feel like I understand where it comes from, but it's so broad, 0.3 to 2. And considering narrowing that down, maybe considering a different pathway for COPD patients versus the neuromuscular disease patients. And I think the other thing is, I don't know how this is possible. I've encountered this before when I've gotten a call in the middle of the night and I've asked the techs, what was this patient's respiratory rate? And I wasn't able to get it. I don't know, with artificial intelligence and things like that, we can get a rate, a resting rate. Hopefully with time we can, so that we get a better backup rate setting, which is probably more in sync with the patient's resting neural rate. Maybe that's something we can add to it, is what I'm thinking.
Great, thank you.
Anusha, I had a quick question, and I think you've answered this before, but I just wanted to clarify because we're talking about it now. When we say neuro resting respiratory rate, that's while the patient is awake, or we're trying to gather their resting kind of breaths while they're sleeping, not obviously during an apneic period, as far as that resting rate amount that we might go to less than?
When they're awake.
When they're awake.
Think about it, when they're asleep, you're thinking it's just less than two or three less than what they are doing during wakefulness. So go back to when they're either doing their calibration or even a little bit before that, to get some sense of what they're doing. Not when they've got the PAP and they're figuring out what this PAP pressure is doing to their face and things like that, where their respiratory rate is all over the place. That's not the best time to calculate it.
Awesome, thanks.
Mm-hmm.
There's some kudos for you in the chat, so take a look at those for sure. I don't see any other hands up or any other questions. So thank you again. That was a great kickoff to our fellow Grand Round season.
All right. Thank you. Have a great day, everyone.
Thank you, Anusha.
Thanks. Bye.
You're my favorite pulmonologist.
You're my favorite neurologist, Josh. Amongst a room of neurologists, I think I got myself in trouble for saying that. Okay. All right. Bye-bye.